Hello, welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. My name is Gio. I am a paralegal / assistant here at Lyles Parker. If you have a quick reminder, if you have any questions during the presentation, please feel free to put them throughout the presentation and we can address all questions at the end of the presentation. So let's get started. So today's webinar is entitled Risks Facing Your Home Health or Hospice Agency if you hire someone on the OIG Exclusion list or the CMS Preclusion list. Today's presenters are Robert Lyles and Paul Wainfield. I'm going to just read a quick bio on both of them. Robert Lyles is one of the managing partners at Lyles Parker. In addition to a law degree, Mr. Lyles holds both an MBA and an MS in healthcare administration. Robert has worked on the provider side as a federal prosecutor and now represents home health, hospice, and other healthcare providers around the country in connection with Medicare, Medicaid, private payer audits, and False Claim Act cases. While working as a federal prosecutor, Robert was asked to serve as the country's first national healthcare fraud coordinator for the Executive Office of the U.S. Attorney. In this capacity, he advised federal prosecutors around the country regarding healthcare fraud statutes, schemes, investigative tools, privacy concerns, and compliance issues. And as for Paul Wainfield, represents providers and individuals in healthcare fraud matters. A former National Healthcare Fraud Coordinator for the Department of Justice, Executive Office, and Assistant to the U.S. Attorney in New Orleans. Paul also has an extensive litigation experience, including approximately 50 trials and about 25 appellate arguments before, among others, the United States Supreme Court, the Federal Fifth Circuit Court of Appeals, and the Louisiana Supreme Court. And I'll pass it to them.
Thank you very much, Gio. Folks, that was Giovanni Nogales. And Mr. Nogales, he as he properly stated, he's a paralegal, but you should also know he's in George Mason Law School here in Washington, D.C. So we're happy to have him part of our team, and you'll probably be hearing more of him in the future. Today we're going to talk about.
He's got a great voice, Robert. Robert, Gio's got a great voice. He should be doing radio.
You're just comparing it to mine. That's true. Yes, absolutely. Maybe he's going down the wrong road here. So today we're going to talk about the risk that your home health or hospice is facing if you hire somebody on the exclusion list or the CMS preclusion list. Next slide. And first, let's just we're going to kind of break this up. First, we're going to kind of give you an overview of what the preclusion list is all about. Then we're going to talk about the exclusion list, and then we're going to compare those and discuss ways that you can really kind of reduce your level of risk. Really, the preclusion list is something that really popped up a few years ago when CMS issued the final rule that made changes to how they were going to be dealing with the Medicare Advantage programs in the future. And part of this was, simply put, it was going to be the Medicare Advantage plans were going to be responsible for their own credentialing and reviewing the providers that want to sign up for the plan. Because before, to be a participating provider in one of the Advantage plans, you had to be a participating provider in Medicare Traditional. When they passed this rule, they really kind of broke those up, didn't they, Paul?
Yeah, so basically CMS cut its work in half because almost half of the almost half of Medicare recipients now, it's over 40% and rising every year, are Medicare Advantage plans, right? And so all the practices, all these doctors that had to get credentialed by Medicare for the plans, now they just go to, now it's the Advantage plans. Of course, maybe now they have to get credentialed twice, I suppose, because CMS.
Well, they would.
Right, because CMS still has to credential them for traditional Medicare, right?
That's right. That's right. Next slide. So one of the things that the preclusion list did, since CMS says we're kind of getting out of the credentialing business when it comes to Advantage plans and Part D, okay? So if it's anything to do with Medicare Part C or Part D, that's something that CMS says, we're not doing the credentialing for that anymore. You guys, essentially, the plans, are going to be responsible for this. And they said, we're going to create this new list that we're going to call the preclusion list. And if you're on the preclusion list, essentially what that means is that your services they can't be paid by Part C or Part D.
It's sort of, yeah. So what they're doing, right, as you've said, is they're kind of handing the reins over to the plans. The plans are already, they're making the decisions on on coverage or not coverage. They're making the decision on, whether they're paying the providers or not. They're supposed to be doing a lot of the enforcement, and so they're handing the reins over to them. Now, they don't. So the preclusion list, everybody that's already on the LEIE, already on the exclusion list, which we'll talk about, is like, I guess they're considered as if they're on the preclusion list, right? I mean, that's
right.
So this is the list. You and I have wrestled with how and why someone gets on this list, because it's people that have not, that if they're on the exclusion list, they're not on this. So it's people that I think, this is how I think. I'm not sure if you agree with this entirely, but I think these are people that CMS is saying, if these people were trying, we would deny them privileges for traditional Medicare, and we think you should deny them the right to be in Medicare Advantage. That's sort of the way I look at it. What do you think? Does that kind of make sense to you, Robert?
No, I think that's exactly correct, because when CMS bifurcated the programs, when they said we're going to break apart traditional from Part C and Part D, it really kind of messed up the program integrity side of it, because when it was all together, if you were excluded, you couldn't participate in anything, right? And that's still kind of the case, but they no longer have control really on who's going to be a provider in Part C and Part D. So they created this preclusion list. And the problem, of course, is that the preclusion list is as wide as it is long. Let's go to the next slide. It really is supposed to protect the patients, as always. But the way they do it, these are their words, not ours. They actually say that they want to keep individuals who have been identified as bad actors out of the program. So these bad actors, they don't want them participating in Part C, which is the Advantage plans, or Part D, which is the Medicare drug plan. Next slide. So let's talk about, what does it take to get on the preclusion list? And there's really two primary categories, okay? The first category to get on the preclusion list is based on the fact that someone has been the subject of a revocation action, okay? So if a Medicare individual, a participating provider, or an entity, if their billing privileges are revoked, now, we could spend a whole day just talking about how broad the revocation bases are to revoke somebody's participating status, all right? But if their privileges have been revoked, okay, and it's still active, there's an active re-enrollment bar. In other words, they've been revoked and it's still active. And CMS, and this is where it gets sticky. CMS also determines that the underlying conduct that led to the revocation is detrimental to the best interests of the program. And how do they figure that out?
Well, can I just jump in right there? Which is really quite an extraordinary thing, because that includes an admission, an absolute admission, that sometimes they revoke people for reasons that are not detrimental to the program. Right?
Well, that's right. That's right. And in fact, last year alone, just relating to telehealth, I know that our attorneys got over 20 revocation actions overturned. Okay, so that just kind of gives you an idea that the underlying basis of being put on the list is really fundamentally flawed in many cases.
Right. And what does it mean? So so they can revoke someone that's not it's not detrimental. For instance, they can't find the address or something, and so would they put those people on the preclusion list? We don't know. We don't.
Well, that's a perfect, yes. That's a great, and in fact, we currently have a case right now. You're going to love this, folks, where the provider had their billing privileges revoked because they were the subject of a virtual site visit. A virtual site. They didn't really show up. They just called them on the phone and couldn't get through to the right person to satisfy them that the place was actually open. So they revoked their billing privileges.
I love that. That's one of my favorites. But
yeah. So looking at what is detrimental? Well, those are the three factors they look at. How serious is it? What is the degree to which the conduct could affect the integrity of the program and any other evidence? Okay, so this is, as you can see, being revoked based on revocation, it really is broad. Yeah, you have to have the underlying revocation action, and it's got to be current. But beyond that, it's pretty much whatever CMS wants it to be. Okay, next slide. All right, now, Paul, this is one that I want you to take the lead on because this one is just, in my opinion, is just crazy.
What? Oh,
this one, yeah. Well,
so,
yeah.
Go ahead.
Behavioral based.
So here's what I don't quite. I suppose how do they come to know? All right. So it says behavioral based, and what it means is that CMS could have revoked them if they had been enrolled. So this is not an enrolled person which they could have revoked, and they determined that the underlying conduct for which they could have revoked them is detrimental to the best interest of the program. And as a final point, so that means the seriousness of the conduct underlying it would cause the revocation, the degree to which the entity could affect the program, Part D, blah, 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 and the other evidence which they deem would be relevant to its determination. So the part that's behind the curtain here is how do they find out about someone who could have been revoked because they haven't been revoked, right? So
right.
I've assumed, but the risk, right, of making assumptions, particularly when it comes to law. So, but I have assumed that these are folks that could have been, since they could have been revoked, that they denied credentialing for Medicare traditional. But it doesn't say that, Robert, does it?
No. No.
So how else would they come to know of these people? I mean, like, are they trolling sort of like the arrest registers or conviction lists for people that haven't sought enrollment but might, and if they did, then they would revoke them? It doesn't make any sense to me. But there it is, and that's the list. And we haven't seen very many who have been put on the preclusion list for this reason. Almost all of the ones that we have seen, I think, Robert, have been for the first one, is the revocation-based ones, not the we could have revoked them if they were applying, but they weren't, so we didn't.
Well, that's true, but the program, even though it's been active now for 4 years or so, is still in its infancy. Last year, there were only 6 cases, 6 people being put on the preclusion list where the individual actually appealed being put on the preclusion list and then took it all the way up to the DAB. Only 6 reported decisions.
Now they do have the same, right? They do. So when you mentioned that, and I think that's important, they do have the same rights as if, and maybe even more rights because they can appeal the underlying conduct, whereas you can't in a revocation, I don't believe, but they can, they have that same administrative process, so they would take longer, as you know.
Yep. But it really is troubling to have, a situation where CMS decides that, well, if you had done this conduct or this behavior and you were in Medicare, because remember, this is really perfect for someone who's a non-participating provider in traditional Medicare, okay? And they engage in conduct that CMS said, well, if you had been in Medicare, we would have revoked you. Well, I'm not in Medicare, okay? But that doesn't mean I can't still apply for Part C and Part D. So that's really where I think a lot of the target is for these people that are smart. If they have issues, they don't even apply to be in Medicare, so they're never revoked to begin with.
So how do they find them, you think, Robert? I mean,
they find them, I believe, because when they fill out the credentialing form, if they fill it out properly and thoroughly, they have to, they have to talk about every place that they've ever been an owner or a manager. They have to talk about all the adverse actions that have befallen them. They have to talk about any convictions that are out there, so that hopefully they would pick it up. Hopefully the Part C and Part D would pick it up in the application itself.
But how would CMS find out about it?
I think that CMS, I think they probably contact CMS and say, this is something we've run across. That's the only thing I can figure, because you're right. I mean, if the plans are doing their own credentialing, they still have to communicate with CMS.
Right. So you think these are people that the plans have actually forwarded to CMS?
I think probably so. Like you say, how are they supposed to know? Because they're not sending anything to CMS.
Right. Unless CMS was targeting non-participating providers.
That's right. That's right. Now, here's where it gets especially sticky for home health and hospice providers. The folks on the phone that own or manage a home health agency, a hospice agency, this is where it gets tough, is you don't really have access to the preclusion list. You don't. In fact, the only time you're going to learn about if someone's on a preclusion list is if the provider or the individual that's put on the preclusion list. It doesn't have to be a provider. It could be they could have an owner or a manager that's been being put on the preclusion list because of their prior conduct. If they come to you and tell you, we received a letter that says they're proposing to put me on the preclusion list, which, Paul, that kind of begs the question. When we're hiring these people at home health and hospice, what do we probably need to do on the front end to try to deal with this?
Yeah, we've been telling people for years, make sure that you ask the question whether you've been excluded or whether you have an exclusion pending, or some action that that may result in an exclusion. But I think so that's been our advice for quite a long time. But now I think you need to extend that question and for the same thing for the preclusion list. That is, have you done anything for the preclusion list that might put you on the preclusion list? And then you might even say that, such as having an adverse action or something along those lines. So they really need, you guys really need to ask it, because home health and hospice, as we know, has enormously transient populations of nurses and providers and folk that get to that visit patients and so forth. So they may have that, and they may not be on an exclusion list anywhere, but it's possible that they're on a preclusion list, and they need to ask that.
And when these individuals are put on the preclusion list, they're supposed to receive a letter that says, hey, it's being proposed that you be put on the preclusion list effective this day. Here's your appeal information.
Right.
So that's what's supposed to happen.
But a lot of times, and we've seen this many times, Robert, people under stress that they've done something that they got that letter, just like if they got a letter about the exclusion list, they just, they don't see it. Or people, how often they don't open mail, or they've moved and haven't had the mail forwarded. So they don't always see that. That's
right. And then the first you're going to hear about it is when you start getting denials for payment.
Right.
Okay, so you got to really watch this. Next slide.
And on that, Robert, on that, when they start getting denials, right? So the Advantage plans are supposed to be screened. They should be screening all of your folk, right? You're screening them, but they're also supposed to be screening. And if they find out about it, then they should contact you. And there's a good question as to whether or not, since you didn't know and couldn't know, whether there's a strong argument for being able to say, well, wait a minute, how can you deny payment for something I had no way of knowing?
Exactly. And that's kind of where it gets sticky. So how long does it stay? How long are you on the preclusion list?
Well, as we say, it's the same. So if it's based on an exclusion, it's when the exclusion is over, then you can reapply for an exclusion. I think you'd also have to reapply to get off the preclusion list. I don't think it's not automatic. Many people think it is to get off the exclusion list. It's not, and I don't think it's automatic to get off the preclusion list. If it's based on the revocation, though, how is that going to work, Robert? I'm kind of
this is real. This is what's so bad, and this is another thing that bothers me about the preclusion list. Okay, because if it's based on a revocation, well, these days, for 2 years now, I guess it is, they changed the rules when it comes to revocations, and they broadened the bases upon which revocation action can be taken, but they also expanded the period of the revocation from 3 years to up to 10 years, okay? So if someone has a 10-year revocation, they're not going to be able to get off the preclusion list until they're eligible to re-enroll in Medicare. Now, that's just almost nutty when you think about the fact that a felony, it could be, of course, 10 years on the exclusion bar. It could be up to lifetime. But most of the felonies, for the most part, they're only for 5 years. That's just normally what OIG does, unless there's a reason for them to extend it further. Okay? So, you're talking about, yeah.
You can always reapply after 5 years, even if you have a 10-year.
That's right. Bar. Yeah, but in this particular case, though, now you've got a revocation that really they're treating a lot more harshly than you would if you were convicted of healthcare fraud.
The whole revocation, the bifurcation of the process has really created a lot of issues in this way.
Yeah. Yeah, now you could also be revoked, by the way, because of a felony conviction, and you're also excluded. Let's say that's for 5 years. It really depends. They could, if they base the preclusion on the revocation, that's one thing. If they base it on the exclusion, that's another. But if they base on the felony conviction itself, which they can, then it's 10 years, okay, unless they determine that a shorter period is warranted. And we haven't seen any cases yet where they've actually done that, where they've backed off of that 10 years. Next slide.
It's 10 years from the conviction, is that right?
Yes, that's correct.
But they will go back. So we have seen cases where that came to their knowledge in some kind of way when you're re-enrolling or whatever, 6 years down the road, and they found it, and they said, okay, well, now you're revoked for the next 4 years.
Yeah, and Paul, you bring up an important point, and that is, you and I have been talking about this for years. The system used to be very imperfect, and it still is in many respects, but I will say that the communication between the agencies, between the feds and the state, interagency between CMS and OIG, it has gotten a lot better, and we're starting to see coordination that we've never seen before. And, it's just really hard. I mean, they're sharing information almost seamlessly, and they're finding out about these things that they never would have found before. So, we're seeing more and more people added to these lists that were not previously on it.
There's also, I would say this, the cynical part of me has to also say that as we see more and more resources involved in coordination and in enforcement of healthcare fraud, they call it, or fraud and abuse, the more resources that you have, the more skins people have to get, the more results people are going to be measured by. People are always measured by what they produce. And the production of an enforcement agency, unfortunately, are suspensions, exclusions, adverse actions. And so that coordination is also a product of their need to get more. Cynically, we would say numbers. Not cynically, we would say in an effort to control healthcare fraud greater. Depends on your perspective.
Yep. Now, one thing I want to point out, it's hard for home health and hospice agencies to find out this information because they don't have access to it, okay? But it's also really important. I put this quote up there about the preclusion list. They make it available to the Medicare Advantage plans and the Part D plans, okay? But look down further in the quote. Part D plans will reject a pharmacy claim or deny a beneficiary's request for reimbursement for a Part D drug that is prescribed by an individual on the preclusion list. So, we're not talking about treating somebody and submitting those services for payment. We're talking about, this is exactly why you have to watch out for not just your staff, but also the people that refer patients to you or write prescriptions for your patients, because you have to watch it. I mean, these pharmacies are told that they have to reject these claims if these people are on the preclusion list or if they're excluded. Okay, so you can have yeah.
Yeah, well, this is something we'll talk about, I think, some more when we get to the exclusion. You bring up a really important point. It's in many ways, it's the elephant in the enforcement room, in that nobody talks about it. But if you think about anybody, the home and health hospice, everything comes by way of a prescription, including all the meds that you have. When in hospice, all the meds, all the services, everything comes by way of a doctor's order. And so in those doctor's orders, people have to be sure that anybody that orders something that then results in your use or your ultimate payment is somebody that you need to be sure of to the best of your ability, that they're not excluded or precluded if possible.
That's exactly right. So you have to know who these people are that are sending you business or writing scripts for your patients.
Right, and we'll talk more in the exclusion side, I believe.
Yeah. Next slide. Okay, credentialing.
By the way, folks can be free to write us questions, I think, because I think we have the ability to look at them. So you and I like to answer questions if anybody has any.
Sure. If you have any questions, just let us know. Now, we already kind of talked briefly about the credentialing process. The way the system is kind of set up now, we have to you have to expect for credentialing questions to come up during the Part C and Part D process, because they are responsible now for doing the credentialing. Next slide. This really is kind of where it comes down on the preclusion side, and I think we've kind of talked about this as well. It's so important that you conduct due diligence before you employ anybody or you contract with anyone, because you want to do what you can to make sure that they're not on the preclusion list, which frankly only goes so far, and it comes down to asking them, and that's all you can do.
That's the best you can do, but our position is that if you ask and if you do everything that you can, then you are, they're saying that they're not going to pay for those services. But if you've done all you can and you've asked in writing, are you the subject of any action that might put you on the preclusion list or the exclusion list or result in an adverse action? That's all, then you have an argument, at least. I've done all that I can. It's entirely unfair. And so I think that that Robert, for instance, if you were handling such a case, I think you would probably prevail in some way in terms of that you could get some traction with those arguments.
Well, it's better than nothing, that's for sure. Next slide.
You're not so sure about the traction, but it is better than nothing.
Yeah, yeah. And then how do you appeal if you get a letter and they tell you they're going to put you on the preclusion list, well, there is actually an established appeals process, and you go through and you tell them, don't put me on it, and here's why. Well, then the secretary CMS will make the initial determination, and if you're not happy with that, then you can file an appeal to an ALJ, request for reconsideration, and then if that didn't go your way, then you can still go and file a request to the Departmental Appeals Board. Now, like I said, there's only been 6 cases last year that went to the Departmental Appeals Board. I haven't found any cases at this point where they have then gone to the next step and appealed it to federal court.
And nobody's won,
okay?
Right? And
no, nobody's won.
Nobody's won. And,
That's right.
And it's almost, but I think that it's worth it, unless the preclusion is because a mass murderer or you've done that something really awful, but I'll let everybody's minds decide what that might be. That it may be worthwhile because you have not been typically on a revocation. It's an agency action. And I guess all agency actions are tough, but this one is kind of vague. And some of those grounds are so vague that I think that if you had a good defense, you could prevail. If the revocation...
It's hard, though. I mean, what are you going to say? I am not a bad actor. I
suppose it would have to be if the revocation were on if it's based on a revocation that was not like some of the ones that you're talking about that were based on a virtual visit, or something that was that was not that kind of thing. I think you might they might not proceed on, but you never know. They like to push the envelope.
That's right, and I feel comfortable that if there was a preclusion action based on a revocation that then we got overturned, I do feel comfortable that CMS would withdraw the preclusion. Okay, I have every reason to believe that they would. But we haven't run across that yet. Next slide. Okay, exclusions. Paul, you're the expert on exclusions. You want to kind of give a little background on the whole exclusion process and mandatory exclusions?
Sure, we'll do it quickly. The idea of an exclusion, keeping bad actors out of the program, goes back quite a ways now, 1977. So that's, that's a long time. 40 some odd years or more, 45 years maybe, close to that. And then the idea, they mandated the exclusion of physicians, just physicians that work hard for certain crimes. And then came the civil money penalties law. That didn't happen. That's still 40 years ago. That was in 81. And finally, in 87, they started looking at this and trying to put some beef to it. They added the idea of they have now mandatory and permissive exclusions. And Robert, the mandatory exclusions are those based on essentially healthcare fraud, criminal healthcare fraud convictions, certain drug-related convictions, mainly sale of drugs, patient abuse, or those are the main areas, and that's it. So fraud-based convictions, and those are a mandatory 5 years at least, and they can be up to their infinite. Permissive exclusions, it sounds like when they call them permissive, it sounds like there's some sort of, oh, I've got a chance with these because they're based on, the discretionary. It's really, it's just a different category. These are almost exclusively, over 95%. These are exclusions based on licensing actions. and you can't deny the action itself. It speaks for itself. So these are, all the doctors who have been licensed have lost their licenses, nurses who have lost their licenses, and so forth. Those are at least 3 years. The big thing is once you're excluded, no matter how long the exclusion is, you have to reapply to get back in the program, right? That's the big deal. In 1996, they do CMPs. The Affordable Care Act expands exclusion authorities. But here's the deal. Everybody asks, where does it say that we have to screen people who are on that list, that we have to screen federal exclusion list? Medicaid, by the way, everybody has that list. Texas has a very strong list that says you have to screen all the employees, vendors, contractors, to see if they've ever been on an exclusion list, if they've ever been excluded from a state or federal program. On the federal side, it's not as clear, but what it does say is if you hire somebody and every service or you do business or you contract with them, then every service is going to be a tainted service. And that's where we go. And then and so we can talk about it. Let's go to the next slide anyway, but that's sort of the broad outline. And so these days, it's now pretty clear that what you have to do is the way to avoid the civil money penalties is to screen every month. So the OIG doesn't say you must screen every month. What they say is if you don't screen every month, then you can get whacked with civil money penalties for every service that's provided by or ordered or provided by an excluded physician, and if you have an employee who's not actually ordering it, then all of the money that you pay to that person, have ever paid to that person in salary, can be problematic. Now, I think we talked about mandatory versus permissive. The big thing about permissive exclusions, I think, Robert, is that these are the exclusions that reach down below your billing physicians, your ordering providers, your doctors, your nurse practitioners, and your other mid-levels. These are the ones that reach down to your nurses, your CNAs, your everybody else, and they are the folk that have hands-on, and they are the ones that you really need to be aware of. They don't show up in a credentialing when you're credentialing them because you don't credential them, right? How do you find out about it, Robert? How can you protect yourself? Because you're not credentialing them, you're hiring them. So what do you do? What do we tell them to do?
Well, on the exclusion side, you got to screen.
Yeah, you got to ask and screen, right?
That's right. But it's not merely enough to ask, because you and I have handled cases where you ask them and they fill out on the application, absolutely not. No, I've never been excluded. Well, people are smart enough to understand, and this probably isn't the first time they've applied for a job. If they're excluded, they know if they put yes, you're never going to hire them.
And there's two things with that. Sometimes, and I always say this because I believe it to be true, and sometimes I say things I guess I don't believe to be true, but I try not to do that. Anyway, that is that people will say they've never been excluded because they don't think that they have. They may not have seen those slips. People under stress, if you've lost your license or you've been convicted of something, you may not even be looking at the mail. I go for weeks without looking at mail, unfortunately.
Well, Paul, that's possible, but I think it's more likely a situation where they're excluded for 3 years in a permissive exclusion, or even 5 years in a mandatory. It's been 10 years, and they think that they're no longer excluded.
I think you're right.
They haven't gone in but if you check, they're still on the list. And even though technically they could have gotten off the list 5 years ago, if you're billing out their services and they're still on that list, you're going to end up paying the price for it. At a minimum, they're going to make you pay back all the money, and that's with no penalties at all. They're going to treat it like an overpayment. More seriously, though, if this is like the second time they've hit you, or if there's something else, some other reason that they think that they want to do it, they're going to try to hit you for some kind of civil monetary penalties.
And it really is true. I think yours is the more likely scenario. Mine, I'm giving everybody the benefit of the doubt in my scenario, but I think yours is the more likely, which is that they, a lot of people go into these things and they're not represented by healthcare lawyers or sophisticated healthcare lawyers. And so we got you a great deal. We're going to wipe it off your record, right? And so it's not going to be on your record, and it's going to be, or we're going to do a no-low contendere or some other thing. And so you'll be fine. And okay, and if you are excluded, it'll only be for 3 years, and then you'll be fine. But as we know, it's not fine. You will be excluded. And not only that, if you are excluded, you don't automatically get back on.
That's right. And the reason why it's not automatic, even though the 3 years may have elapsed, they make you fill out an application. And you're going to have to account for every job you've had while you've been excluded. And the reason is because if you've been working in healthcare, they're going to go after you and they're going to go after the provider because they weren't screening, okay? Because you're not supposed to be working for any kind of participating provider during that exclusion period.
That's a really good point, Robert. We've filled out those forms for people trying to get back on, and it's it's more rigorous than most licensing applications. I mean, it's certainly more rigorous, at least more rigorous than most credentialing applications, really, because it goes.
Yep.
Exactly what you've done and who you've done it for, and so you've been working for so and so. Well, I think I better go check that out. So we can go to
That's right.
I think we can go to the next slide, Gio. Here we are. Oh, this is our favorite. Robert, you were the one that found the paladindeception.com and brought it to my attention. So I'll let you. This is like our favorite slide.
Well, a lot of times we hear from our clients and they'll say, well, we don't need to use exclusion screening services because we do a background check. Background checks, I'm sorry. If it's not through the government, for instance, in Texas, you can go and you can check the nurse registry and you can check the conviction list there of folks like you're supposed to, the criminal conviction registry. That's from the government. That's one thing, but that's not a complete background check. That's just to see if the government has hit them with anything. But these background check companies, as good as they may be, if they're calling up to check on somebody's references, to verify prior employment, even to see if in fact they have a degree from a college, you better be really careful, because there are companies out there, and I checked all 3 of these before we did the presentation today. These are all still active on the web. You can literally go to these companies and create a whole new persona. You can recreate your work history. You can get professional references. You can get neighbors. It's really quite amazing. The bottom line is, background checks are, I believe, very flawed.
It's like going to camp when you're a kid. You could make up a whole new self. Nobody knew you, and so you could just start all over. Well, that's what these things are like. They'll say, what line, what area do you want? What kind of degrees do you need? That you can have up to 3 phone numbers, local numbers for references. And you check the box, and there it is. And it depends on, anywhere from the cheap ones are as little as $60 or something like that.
It's really scary, because if you've got someone, for instance, who doesn't have a criminal conviction in their background, so it's not going to pop up, but they've got just a really crappy work history, and they've done some horrible things at the places they've worked. When they fill out those applications, if they put down these fictitious references and work addresses and the rest of it, you've got a real problem. Yeah. How are you going to know?
And it really, one of the things that we know that in this industry, like in most of healthcare, and particularly these days, there's always a crisis of a shortage of qualified staff.
That's right.
It's just the reality of the business, and it goes and it's day by day. And so you're always like, oh, we need somebody, and staffing companies, they're unreliable, and or they're expensive, or there's lots of reasons that you don't want to use them. But you really you've got to try and dig a little bit, particularly before you hire them. At least screen them. Absolutely screen everybody before the,
Yep.
Don't hire them and then screen them. Screen them first.
Before they walk in the door. Absolutely. All right, next slide.
We'll let you do that.
All right, so, who do you have to screen? Now, remember, we're just talking about exclusions now because you don't have the list for preclusions. But for exclusions, you have to be broad because remember, it's not just the providers that are providing billable services, the people whose names are actually on the billing forms. It's anyone that really contributes to that basket of services. It would be anyone from your receptionist to other non-clinical people that really kind of contribute at your organization. But you even have to do vendors and you got to do vendors and contractors.
Right. And so if they're direct, and so yes, you have to. It's a broad stretch, and what they call the payment prohibition is that any service that they contribute to directly or indirectly. So you can't have somebody who's been excluded and have them sell it to somebody who has not been excluded, and then to receive it from that other somebody as a subterfuge. Because he's a good guy, and he's and really he can't do that. He cannot do that.
That's right. All right, and even volunteers. You have someone that wants to volunteer because they want to get credit for school. You have to screen them too.
In fact, the OIG specifically in their guidance said even volunteers, to everybody's surprise, but it makes sense.
Yep. That's right. Okay, next slide. All right, so what are the differences between the two? Okay, well, we've already talked about them, and this is just kind of a summary. We're going to summarize everything. The exclusion list it can be mandatory or permissive. It typically results from criminal convictions or a licensure action or some other adverse action that fits within one of those permissive exclusion categories. Whereas the preclusion list, that's really just for Part C and Part D, and it's not to be used as a substitute for checking the exclusion list.
No.
Okay.
And you don't know what's on it. You've got it's sort of like Jell-O and like my grandmother's certain fruitcake or something. Soft versus hard. You know what it is, and the other one is you don't.
And that kind of goes to the purpose. The purpose of it, of course, is the whole purpose of the exclusion authority. Okay, it's not a gotcha. You have to understand the whole purpose of Congress passing the requirement that convicted felons and the other folks be excluded from participating in the program is they don't want people with certain types of a history of bad conduct treating Medicare and Medicaid and other federal health program beneficiaries. They're trying to protect the patients. That's really what it comes down to. That's what all this is about. Even the preclusion side, that's what this is all about.
And also, in addition, they make no bones about this. They say, whenever these are people who are deemed to be a risk to patients, but also someone who's been a risk to the program. And that's why the fraud.
Thank you, Paul. I should have mentioned that. I didn't mention that. You're right. It's not just to the patients. It's also to protect the program.
That's right. Which is reasonable. It's if you got a fraudster, right, then you don't want him billing Medicare. Because he's going to fraud.
That's right. Now, the exclusion list, who has access? Well, technically, everyone has access to the exclusion list, but you have to be careful. It's not your obligation as a provider, especially in Texas. You can't just check the OIG LEIE, which is the OIG exclusion list. Okay, to be thorough. you really need to check that. You need to check the state Medicaid exclusion lists, and you need to check the GSA debarment list. Okay, all of those are publicly available, but it's really physically impossible for any provider to do it.
Right.
And that's why, you have to use somebody like exclusion screening.
These are the OIG exclusion list and the state list are considered public notice. It's as if they hung them up on a wall and said, you need to check these things every month. Now, the reality is they put them in weird places. They're hard to find. And frankly, for any individual provider, it's an impossible task. And they really should get some sort of vendor to help them do that, because they are considered, no matter how hard it is to find them, they're considered public notice. And if you don't see them, then you can be penalized.
Whereas now, in contrast to the exclusion list, the preclusion list, as we talked about, unfortunately, nobody on this call has access to it.
Or at least nobody that we know of.
That's right. Unless you're working for one of the plans, you don't have access to it. Now, I can tell you that exclusion screening, well, no, they do screens for some of the plans, so they would see it, but they can't share that information with any providers.
And they actually have to, and exclusion screening, they actually have to build a wall so that, for each time it's brand new, they only can do it for the plans. They're not allowed to do it for any individual, and they don't.
That's right. Yep. Next slide. What about the size, Paul?
Well, there's about 75,000 people in the OIG's list, and that's it goes back. They trim it. The people come off, they pull them off. There's about 75,000 of them, and about 85,000 or so in all the state Medicaid lists. There are, as compared to the preclusion list, it's 4,600, but growing at a pretty quick pace. I'm not really sure, since we don't really have access to it. There's no way, we can analyze where they come from on the OIG. I can tell you how many are based on fraud, convictions, how many based on abuse or loss of license. I can find that out. I don't have any access to do that for the preclusion list. We don't know where they come from necessarily, but 4,600, which is plus all of the ones on the OIG list, are considered as if precluded.
That's right.
So.
Next slide. Potential penalties. This is what everybody worries about. On the exclusion side, you have to understand, guys, this can range anywhere from being treated as a mere overpayment. It can be treated as a civil monetary penalty. We've seen cases filed under the False Claims Act where someone knew that an individual was excluded and the government went after him. And we've actually seen several criminal actions where, mostly on the East Coast, where a practice knew that someone was excluded. They would hire them under the table, if you will, to provide medical services, and then they would knowingly bill it out under another provider's number. Okay, so the government looks at each one of these violations very carefully to see what the facts are. Did you just make a mistake? Did you fail to spell the name right? That's an overpayment. Did you fail to do it when they first came in? You waited to do it, once a month. That's an overpayment. But it can be a lot worse. Okay, so this is not something. They are not to be trifled with. OIG does not mess around. They will go after you.
Yep. I would say there are two real areas where you're at risk, and the first one that is the one you just said, which is that you try and get around it. That is, you have someone who is excluded, and you have them participate, but you bill it under someone's number who's not excluded, and you try and hide that fact. If you do that, you are really making, I would say, a bad mistake, because that's the kind of conduct they punish severely. The second one, which is not quite as severe, but that they really take umbrage at, is someone who someone's excluded and you let it go, okay? Or you don't report it, and you don't, or you don't take any action about it, or you have noticed that they should have been excluded. We've had people who have said, "Oh yeah, we thought it might be excluded," and then they find out that they were. If you know someone, if you have an idea that someone's about to be excluded, or that someone has been excluded, and you don't look and you don't screen and you just let it go, because we've seen even at self-disclosures where the government, I think, Robert, you would agree, and we would both agree, is usually pretty reasonable under self-disclosures. They only, if they're not a billing provider, they only look to get back the money that was paid, and they listen to your complaints. And you've had several where they said, look, they're so small, we're not even going to worry about it. Just deal with the contractor. But I've also seen self-disclosures in the hundreds, several hundreds of thousands of dollars. So, not taking care of an issue that you know is there, that will really get the burr in their saddle.
That's right. Next slide. The length, we kind of talked about this already. It varies a lot. It depends on the preclusion side. It depends on if it's based on a revocation, which of course is the length of the revocation. If it's based on an exclusion, that's the length of the exclusion. If it's based on a criminal conviction, that's typically 10 years. On the exclusion side, at a minimum, if it's a permissive exclusion, it's 3 years. If it's a mandatory exclusion, it's a minimum of 5 years. But we've seen a number of cases where they have excluded somebody for 20 years or even a lifetime exclusion. There have been several press releases just this year where, as part of the settlement with the government, the provider agreed to a lifetime exclusion.
Yep, we've seen that. The one tricky part that I would say is, even no matter what the length of the exclusion, understanding that many exclusions, almost all the permissive exclusions, are based on a licensing action. The law says there are rules that say that even if it's a 3-year exclusion, you have to resolve that licensing issue before you can get off the list, and that can be really tricky. We've had a lot of, because a lot of times if you've lost the license, the agency sort of, whoever gave you the license is sort of done with you, and you're done with them, and there's really no going back. So it can almost turn into a lifetime exclusion unless you are careful about it. That can be.
That's right.
That's a problem.
Next slide. Okay, so this is just these are the final questions. We've kind of talked about how many folks are on each list. What does it take to be put on a list? Can you check it? Well, sometimes yes. If it's always yes if it's exclusion. If it's preclusion, no. What happens if you actually hire somebody? What are the potential penalties that you face? And then what is what happens when their name drops off the list? Can they reapply, re-enroll? And that's what you have to do. And that pretty much, I believe, concludes our presentation. Do we have any questions?
I don't see any written questions.
Well, we've got here. Liz, can you read us any questions?
Yeah, I'm going to go ahead and read this list here.
Oh,
let's see. Do you see them on your end?
No, don't.
Okay. Here we go. First question. What types of behavior would they be referring to? Fraud behavior. Do you have more examples? Examples of fraud.
All right. So if it's I assume they're talking about the conduct or behavioral-based preclusion action. Okay. So let's assume, just as an example, let's say we have a provider who is not a participating provider in the Medicare program, and he's convicted of fraud. And if, in fact, he were participating, then they could always exclude him, or they could always revoke him. But he's not participating. But he turns around then and he turns around and applies to participate in the Advantage Plan or Part D. That's the kind of behavior that, if he had been a participating provider in Medicare, it would have resulted in a revocation. It probably would have resulted in, or might have resulted in, an exclusion, depending on the type of conviction. But that's what they're kind of looking at. You know, what's the underlying conduct, and if the provider had been participating in traditional Medicare, could that have resulted in some type of an action being taken against them?
So, and I think also when they're talking about fraud, at least in the exclusion context, they're usually talking about convictions of a conviction, either it could be a felony or misdemeanor, that in connection with the delivery or the provision of a healthcare service. That's the kind of fraud that they're focusing on. They're not really focusing on the used car dealer who does, you know, a 3-card Monte or something like that. The fraud that we're talking about is generally that which results in some sort of conviction, and they can see, and Robert, right, they consider a conviction a no-low plea, or even.
Oh gosh, you and I both know. I mean, a conviction is not necessarily a conviction. A conviction is a lot of things. Right. The definition of it under the federal statute is quite broad. So you got to be really careful. And this kind of goes to your point. You can have a great white-collar lawyer that gets you an incredible deal with the government, but you just have to make sure that you run all the traps, because the collateral consequences of taking a plea or accepting some type of conviction or anything along those lines, the collateral consequences can be devastating.
Right, you are.
All right. Next question. This asker says, CMS sends me an email of the updated preclusion list each month. Is that something you would suggest people sign up for to know when it was updated and to go check it monthly?
The preclusion list. I would love for you to call me. I would love to see that, because by statute, they're not supposed to be sharing it with anybody except Part C and Part D payers.
Right. And it might be and they do put out a notice. It's like they do update the exclusion list like the first, usually about the 7th through the 10th of every month. And they do post that notice. And, you know, they do send it to their listserv of however many hundreds of thousands. And so that may be what you're seeing. But as Robert says, if CMS owns the preclusion list, if they're sending that, they think you're they believe that you are a Medicare Advantage plan or a Part D drug plan. And I'd like to meet you.
Yeah. I think folks have got a couple other questions, but we're going to have to kind of wrap it up, and we'll have to deal with those individually.
Yeah.
Because we're out of time, unfortunately. So we really appreciate you taking time out and talking to us. And if you do have further questions, always feel free to give me a call or give Paul a call. We'll be happy to help you. Thank you.
Yes. Thank you all for attending, and enjoy the rest of your day.